Welcome back to our Masterclass Explainer. Let's jump right into how we accurately code for getting patients back to their actual daily lives and work. We've already tackled basic exercises, but today is all about real-world application and, importantly, securing the proper reimbursement for it. We're talking functional and reintegration training.
So how exactly do you code for real-life recovery? The overarching goal of physical therapy is functional restoration, right? Ultimately, we're trying to get people back to their activities of daily living, their ADLs, and their instrumental ADLs, like managing their finances or going grocery shopping. We aren't just fixing a joint or a muscle in a vacuum. We're restoring a patient's ability to actually navigate their own life.
Here is our roadmap for today. We'll start with a quick functional restoration overview, move into the code breakdown and clinical scope, tackle proving medical necessity, and wrap up with a teaser for next time.
Let's kick things off with Section 1, our functional restoration overview. Physical therapy isn't just about reducing pain. At its core, it's about giving patients their independence back. And this really applies across the board. Whether you're treating an office worker who literally just needs to sit at a desk without debilitating sciatica, or a senior with mobility challenges who's trying to prevent falls, the end goal is always improving that quality of life. Every exercise, every stretch is tailored to safely perform those ADLs. So for payers, this translates to you proving that the therapy is returning them to a functional, independent state, not just giving them a general fitness routine.
All right, moving into Section 2, the code breakdown and clinical scope.
Take a look at the contrast between our standard direct contact codes and the much more rigorous work hardening codes. 97530, 97535, and 97542 are based on your standard 15-minute increments requiring direct one-on-one contact. But then, look at 97545 at the bottom. The time rule jumps dramatically to an initial 2 hours. Let's unpack each of these so we really understand their unique clinical scope.
First up is 97530, which is all about dynamic, real-life movement. The key phrase to remember here is functional performance in a progressive manner. This code is completely distinct from a basic therapeutic exercise, simply because you are actively simulating the functional tasks that the patient actually needs to perform in their everyday life.
For example, if your therapist is having a patient practice card transfers, or lifting, or bed mobility, this is absolutely the functional performance code you're looking for. It also covers things like carrying, pushing, pulling, catching, throwing, and even fine motor dynamic tasks like pinching and grasping. Basically, if a patient is lunging, jumping, or doing overhead activities specifically to simulate a functional task, 97530 is your go-to.
But here is the crucial catch, and it comes down to this number, 15. You have to have 15 minutes of direct, one-on-one patient contact to build this code. The provider cannot be off in the corner documenting another chart. They must be directly engaged with the patient, actively guiding those dynamic activities. If the provider steps away, that clock stops. Period.
Now, let's shift gears to 97535 and 97537. These shift the focus directly to daily survival and reintegration skills. While 97530 was about the physical mechanics of a dynamic movement, these codes are all about the actual tasks themselves.
We're talking everything from basic personal hygiene and cooking to higher-level community tasks like managing money. CPT 97535 covers your in-home ADLs, bathing, grooming, dressing, basic household cleaning, medication management, and learning how to safely use adaptive equipment. Going a bit broader, CPT 97537 covers community and work reintegration, so shopping, using transportation, managing money, and analyzing work environments. And again, both of these are billed in direct, one-on-one, 15-minute increments.
Moving right along, CPT 97542 is highly specific. It covers the assessment, fitting, and actual propulsion training for wheelchairs, also in 15-minute increments. It's incredibly important to note that this isn't just about handing a patient a chair and sending them on their way. This covers the comprehensive evaluation by a PT to ensure the chair fits, checking positioning and supports, and extensively training the patient, and often their caregivers, on how to safely propel and manage that wheelchair. Finally, we have work hardening, which uses CPT 97545 and the add-on code 97546. This is a massive step up in intensity. The whole goal here is to comprehensively simulate the patient's actual work environment to get them back on the job safely. And because of this intensity, the time rules change drastically. This is a major contrast to the codes we just talked about. Work hardening requires an initial threshold of 2 full hours. You bill $97545 for that entire initial 2-hour block. If the conditioning extends beyond that, then you use the add-on code 97546 for each additional hour. It's an intensely comprehensive rehabilitation process.
All right, Section 3, Proving Medical Necessity and Intent. Because, let's be honest, knowing the codes is only half the battle. Defending them in your documentation is where the real magic happens.
Now this is truly fascinating. The exact same physical movement, getting out of bed, changes codes entirely based on clinical intent. Think about that. If a physical therapist has a patient practice getting out of bed specifically to facilitate dissociative movement between the lumbar and thoracic segments to improve proprioception, you bill CPT 97112, neuromuscular re-education. But if that exact same movement is being practiced simply to improve the functional performance of safely getting out of bed, you bill CPT 97530, therapeutic activities.
And that brings us to the golden rule for coders and clinicians, straight from the source material. Intent dictates the code. You cannot just look at a picture of a patient's exercise and magically know how to code it. You have to read the clinician's notes to understand why they were doing it.
So to prove medical necessity, your initial evaluation and your progress notes must follow these logical steps to show exactly why skilled therapy is needed. First, what brings the patient in? Second, what is the objective description of how their function has actually changed? Third, you must quantify their progress, or even lack thereof, with objective impairment testing. And fourth, always detail status changes relative to the specific short and long-term goals you established.
On top of that, make sure you're clearly documenting all issued equipment, home program updates, and any communication with the patient's care network. Did you update their home exercise program? Note it. Did you consult with their primary care physician or a nurse? Document it. Did you train a family member on how to help the patient with meal prep using adaptive equipment? Get it all on the chart. Without these details, you're leaving an incomplete picture of the comprehensive, medically necessary care that you provided.
And this brings us to our absolute bottom line for documentation. Simply stating decline in function on a chart is never, ever going to be enough for a pair. Think about it. Anyone can have a decline in function. Your documentation must clearly establish that this specific patient needs the unique, skilled interventions of a physical therapist to improve that functioning.
Section 4, Outro and Teaser. That wraps up our deep dive into functional and reintegration codes for today. We have covered a lot of ground, from dynamic activities in self-care to those intense 2-hour blocks of work hardening.
As you review your notes this week, I want you to ask yourself if your documentation clearly reflects the clinical mindset behind the exercises. If an auditor pulls your chart, will they instantly see your intent, or are they just going to see a list of generic movements? Remember, intent is everything. What dictates your coding choices? The physical movement or the clinical mindset? Make sure you join me in part 11 of this explainer series where we are going to completely demystify the overlapping rules between therapeutic exercises, neuromuscular re-education, and therapeutic activities. We're going to take that concept of clinical intent we discussed today and blow it wide open. Until next time, decode healthcare with Harshal.